My name is Ryan Tazel. I'm a physical therapist.
My name is Greg Whitcomb, and I'm a chiropractor at the Medical College of Wisconsin. When you get an older patient that just is intrinsically less mobile, thrust manipulation can be counterproductive. So there's a time and a place, typically the younger patient population, and that tends to be more of an end-stage manipulation process for me. So I might engage, depending on the acuity of the patient's pain and how much immobility they have and how much of that stiffness that is in the spine I think is functional versus structural. I will start to mobilize with low force techniques and then move into that as the patient can tolerate it. So put in as much motion as they can tolerate, and as they can tolerate more, add more up to. And if we can get to that point, that's when I see patients really start to take off, to be quite honest with you. They can tolerate high velocity, low amplitude manipulation. We're almost done at that point, right? So now they're coming to me, they're telling me that what once had been painful range for them, I can't extend my neck. Now all of a sudden they can extend their neck and their pain is decreasing. Then we've got to go from the sort of mobilization, manipulation to the stabilization part of the process, which is where I really rely on my physical therapy colleagues.
Yeah, very good. So do you find that you use HVLAs more for pain or for motion or both?
My personal sense is more for motion.
Okay.
And pain notwithstanding. And this is something too, I mean, we've both worked on patients enough to know that this trust factor with the hands, it has to be addressed. Patients need to know that they have to, I address risk factors with them. I address what it's going to feel like. I get their permission. I introduce my hands into their spine so they get a sense of what's going on. Because if they can't work with me, not a whole lot's going to happen that's positive.
Exactly. Yeah. That's great.
Yeah.
I don't use HVLAs much. I was trained to use them. I use more low velocity, low amplitude as a means of both reducing pain, increasing range of motion.
Right.
Yeah.
Well, do you think that there's an interrelationship? So as range increases, do you tend to see pain decrease, or do you think range increases as a result of pain decreasing, or does it matter to you?
I find both, and I think they both pain and range of motion respond independently, because we've seen this before where there's somebody that has great range of motion but they have pain.
Lots of pain, right?
Yeah, and some people that have no range of motion.
I tend to think that candidate's probably not a super great candidate for manual treatment to begin with. Right,
yeah, and that's just experiential. Right. Yeah.
Right. I mean, those people need more stabilization, more motor control strategies than dealing with the pain and stiffness.
Right.
So
activation. They need to be active. Yeah.
No question.
Yeah.